Started. Perfect. And let's do a little quick intro. Okay, everybody, we're glad to have you here today. And those who are online, we have Dr. Anu Abraham. She was with the University of Utah. She recently moved over to St. Mark's at Lone Peak. We're glad to have her on board. She's an interventional cardiologist, and she's a great part of our team. I'm looking forward to that. So, 10 years with the U, then back here? From New York, but you lost your accent.
From New York, I lost my accent. I moved back and forth from one coast to the other. Well, thank you for giving me this opportunity to talk to you. So I will say that the inspiration for this came from the husband of one of my best friends from medical school, who's a New York City firefighter. So he had said if I was listening to a cardiologist talk to me, I'd want to know about cardiovascular screening and what I would need to do in order to get screened and get taken care of. So we can thank Jimmy for this. So what I wanted to talk about today was to go over non-invasive testing and cardiovascular screening, sort of in the outpatient realm. I know that everybody here knows how to manage acute chest pain, so I don't want to belabor that, but kind of talk a little bit outside your comfort zone about things that I think are important for you and for people that you're seeing out in the field. So acute chest pain accounts for 5 to 10% of all ER attendances and 10% of EMS calls. Over 7 million presentations to the ED annually for chest pain. So it's obviously a really big part of people that we take care of. And so kind of want to steer people in the right direction. So the formatting kind of messed up a little bit. I'm sorry about that. But I think acute chest pain is stuff that you know how to deal with. I think it's almost, in my mind, simple. Acute chest pain, EKG, STEMI, call us, and we get them in for angiogram and PCI and the meds and things like that we administer, sort of kind of all formulated, and it's sort of an easier pathway. It's the people who are less obvious coming in with chest pain that sort of make it a little bit more of a challenge to manage. So chest pain is very common. Lifetime prevalence of chest pain, 20 to 40%. So we talked about this already. Over 67 million people come to the ER with chest pain. But not all chest pain is cardiac. About 5% of acute chest pain is actually ACS. As you probably already know, women experience more chest pain within the population, but less prevalence of obstructive or symptomatic coronary disease. And when you look at people who come into the emergency room with ACS, they're not all presenting in the same way. Some of them have typical acute chest pain. Some of them have atypical pain. Some of them just have shortness of breath. Some of them come in because of syncope. Some of them come in because of palpitations. I think there's a really broad range of how people present, but I think that's what makes it sort of interesting to kind of shuffle people down to different pathways and kind of sort it out. So this is sort of an extension of that first pathway that I showed you. So, if they're STEMI, okay, we have like a very organized pathway for that. But if they're not, I think that a lot of their chest pain is patient-centric and kind of utilize the testing based on risk factors, pretest probability, lab work, diagnostic testing, and kind of move on from there. But obviously, chest pain can be many things. It could be pulmonary emboli, valvular disease, myocarditis, pericarditis, aortic dissection. So a lot of these things, I think, kind of a lot of the etiologies will guide us. So this is I just wanted to talk about this in terms of cases and kind of share your thoughts along the way. So it's a 54-year-old guy who was coming in for evaluation of chest discomfort. It doesn't say whether it's his pain started about 3 months ago. And it occurs really with just severe emotional episodes. It lasts a few minutes and then resolves without any intervention. He has no associated shortness of breath, diaphoresis, and he says it occurs about once a week. His only medical history is hypothyroidism. He's an occasional social smoker, drug use, occasional alcohol. Father had an MI at an older age, and his mother had diabetes. And pretty unremarkable physical exam and vitals. So in terms of history, when people come in describing cardiac symptoms, most people actually won't describe actual chest pain. I had a patient in the office the other day who I kept on saying, he said, "Doctor, you're saying chest pain, but it's not chest pain. It's actually just chest tightness." And so different people describe it differently. But squeezing, gripping, some people say suffocating, pressure, heaviness. And I will say more commonly, I'm more convinced if people tell me that the pain is like kind of butterflies versus someone who says right here, it hurts right here, or they point to it with a finger. Typical angina improves with rest. It gets better in a few minutes or 50%. It's rarely described as a sharp stabbing pain. I think if that's the case, I'm thinking of other possibilities. And it shouldn't vary with position or respiration. That would, if it does, that would be more of a pericardial process. And it's not reproducible. Obviously, that's more consistent with the musculoskeletal TBL. So obviously, you know, you're coming in with chest pain, we're going to get an EKG. What is the role of the EKG here? So obviously it's best obtained in a person actually having chest pain. So you see ST elevations, ST depressions, T waves, new left bundle. I think that kind of steers you down one pathway. And, you know, obviously in that setting, it allows for immediate identification and understanding. But if you're not having chest pain, it still may provide a lot of good information, whether or not you've had an old MI, whether or not you have an underlying arrhythmia. And, you know, a small percentage of people who have ACS do have a normal EKG. So what do we do with folks who have stable chest pain, but they're coming in to get evaluated? So stable chest pain, as you already know, is a symptom of ischemia. And it can be characterized by chest pain that's provoked stress, and it could be physical or emotional stress. And on the right is sort of a graph, a table that kind of talks about, kind of gives us a pretest probability for obstructive coronary disease in symptomatic patients. So that light green, those light green boxes sort of mark people who are low risk, dark green or high risk, and the orange are high risk or high pretest probability for coronary disease. So a lot of what we do is going to change based on their pretest probability. So if I have like a guy who's like 65 and is a smoker and has exertional chest pain, you know, even if I do a stress test and for some reason it's negative, the pretest probability of coronary disease is high that I would probably not even care that a stress test is negative. Gosh, probably get an angiogram. So this sort of describes this sort of risk stratification. I think in the center, on the top of that pyramid, you have people who are high risk for coronary disease, and those are people who you shuffle down to get to see whether or not stenting will help improve symptoms. And then those folks who are intermediate risk to high risk, I think if they're stable, we could talk about functional testing and kind of figuring out what would benefit them if they do have coronary disease and whether or not, you know, angiogram is the right thing to do. And then for low risk people, we actually don't recommend risk stratification at all. We want to manage their other cardiac risk factors, but don't need to do any sort of like stress testing or anything. So I'm sorry that this kind of got changed. I'm sorry. So the top part that's obscure just talks about how patient presentations have changed over the course of the past 20 years in terms of how people present. So most people actually don't present with typical angina. And the symptoms can be infrequent. They can be once a month, once a week. I think that, you know, when we see people in the office or in the emergency room, we are reassured when we hear that pain happens pretty reliably. It's the infrequency that makes it a little unsure of what the next steps should be. In general, people undergo a lot of diagnostic testing, and this leads to a lot of angiograms and there actually is like a lot of completely normal angiograms out there. So I think in like an setting, more often than not, like abnormal stress testing will lead to an angiogram, rightly so, but a lot of those tests, but a lot of the angiograms are actually quite normal. So a lot of people have chest pain that's not necessarily from epicardial coronary artery disease. So now you see these people, and you see this guy in the office. He's having infrequent pain. It seems fairly reliable that it's stress related. He's an occasional smoker. I didn't ask about his exercise capacity or anything like that. But his father had an MI at an earlier age. So I think he has enough risk factors that he kind of sits in an intermediate risk category. So I do need to do something else to kind of understand whether or not his chest pain is related to coronary disease. So there's a couple different ways that we can do this. One is to do anatomic testing. And that's a CT angiogram, a CTA coronary angiogram. So this is essentially like a non-invasive angiogram. So instead of going to the cath lab, I can take them to the CT scanner and get a sense of what the coronary arteries look like. So it's just used with, so it's just a regular CT scanner. It has great sensitivity, great specificity, and like I said, it's essentially like a virtual angiogram. So when I used to do a lot of outreach in Tooele and stuff like that, I would actually send a lot of people for like CTAs because rather than have them come all the way to Salt Lake, I think this gives us a lot of information. And it helps us understand, you know, plaque characterization. So if you have a calcified plaque versus a soft plaque, it kind of gives me more information in terms of how aggressive I need to be. But there are problems with every test, and you know there are a couple issues with coronary CTAs. One is that if you have too much calcium, then I can't really tell you what's happening in your vessel because the calcium will just be super reflective and can't tell what's beyond that. So I can't tell you whether or not there's a lot of stenosis there. And the second issue is that if your heart rate's really fast or you have AFib, if your heart's super fast, it's not going to stay still enough for the test, and I can't really tell what's going on. So when you do a CTA, we drop your heart rate down really low with metoprolol, like an hour before the test to get your heart rate down to like 60 so that we can really have a good look at the heart arteries. So who's an optimal patient for a coronary CTA? It's folks who are younger, less than 60 years old, ideally, who are low to intermediate risk for obstructive coronary disease. People who are not tachycardic, so they don't have AFib with RVR, and who can tolerate beta blockers. The positives of this is that, like I said, it's a virtual angiogram, so we can even tell you the degree of stenosis with a coronary CTA, and we can see what the actual plaque morphology is, which, like I said, might help me decide to be more aggressive about angiography versus medications. And it has a great negative predictive value. So if your CTA is negative, then I can say very confidently your chest pain is probably not because of epicardial cardiac disease. Let's look for alternative etiologies. So I don't love to put papers in my talk, but this was just to show that, you know, the coronary CTA is really good. And if you look at people who have stable chest pain, who go to a clinic and have a CTA plus your normal standard of care, so like hypertension management, lipid management, diet, exercise, nutrition, counseling, if you add a CTA to that therapy and you look at their risk of having, you know, non-fatal MI or death from CAD at 5 years, the people who had the CTA, in addition to standard care, actually had better outcomes. So I think it is very valuable for us to do to at least risk stratify and help manage patients. And importantly, it didn't cause a larger rate of like coronary angiograms or revascularization compared to the standard care. So that's anatomic testing. And then the next part is stress testing. So this is different. This tells me a little bit different information about a person and kind of what happens when they do get pushed physically on a treadmill or with medication. So there's different modalities. There's a treadmill stress test. There is a exercise treadmill where you just run on the treadmill and just are attached to ECG leads. There's nuclear stress testing and cardiac MRI stress testing. So for stress testing, obviously the best person for this would be someone who's able to exercise, who has a reasonable body habitus, who can actually, because when you do a stress test, it's actually more of an incline rather than increase in speed during the test. And it gives us a lot of great information. It tells us about someone's functional assessment and whether or not that's, any of the pain is related to EKG changes or echocardiographic changes. It gives us basic structural information on the heart and tells us about whether or not someone has valvular disease. And there's a really good balance of sensitivity and specificity. So a really good negative predictive value. So if it's negative, you can feel fairly confident that their risk of having a cardiac event is less than 1% in a year. So as I said, there's stress where you run on the treadmill, so exercise, or pharmacologic where we can give medications like dobutamine to help augment heart rate and to look at signs of ischemia. So we look at the ECG and the echo. And ideally, it's more sensitive for people who have blockages in the proximal vessels. So like your proximal LAD, your right coronary artery, your circumflex, or if you have multi-vessel disease, then you're more likely to see a positive result on the stress test. So again, there's problems with everything. So, you need the patient to be able to get to an adequate cardiac workload. It's less sensitive if you have like one vessel coronary disease. And obviously, if we're looking at an echo, we want to make sure that there's good image quality. And if the patient already has like some pre-existing, wall motion, like weakness in one of the walls, it makes it a little bit more challenging to manipulate. But we can, I just think it's a little bit more challenging. So that's exercise and pharmacologic stress echocardiography. And then there's nuclear stress testing. So this is ideal for a regular person who can't necessarily run on a treadmill or can't tolerate dobutamine. So what we do is we give a medication called regadenoson, which actually dilates the vessels, the coronary vessels. So in people who have blockages in the heart arteries, normal vessels will dilate. The disease portion won't. And so you'll see differences in how the radio tracer gets taken up by the heart muscle. And you can kind of see if there's decreased uptake, then that suggests decreased oxygen or decreased perfusion in that area. So the benefits of nuclear stress testing is that it's really widely available. And like I said, it's ideal for people who can't run on a treadmill. So we have lots of options for kinds of stress tests that we can choose. Which one should we choose? I will say that in general, the sensitivity and specificity are pretty similar across the different stress tests. So I think that all are very reasonable to try. And at the end of the day, it's all about what is best for the patient. So in someone like the person who the case presentation was about, seemed very reasonable to get on a treadmill and run and do a stress echocardiogram, a treadmill stress echocardiogram. If the person was, a 65-year-old obese diabetic, potentially a nuclear stress test would be a little bit of a better choice for that person. So it's all about what's best for the patient, but just know that all of these modalities have pretty reasonable or pretty similar sensitivity and specificity, such that I think if you had one is not necessarily massively better than the other. So that's sort of kind of an overview of options we have. And this is very commonly calls that we get from the ER for people who come in with chest pain. What kind of stress test do we need to get? And how do we steer people in different directions? So this is a little bit different. This is sort of someone who doesn't have known coronary disease, but is coming to kind of talk about, risk stratification and management of cardiac risk factors. So it's a 46-year-old man who presented for risk assessment. He's got no cardiovascular symptoms, so he's able to do what he needs to do, not limited by chest pain or shortness of breath. His medical history is notable for some reflux, and he takes tons of needed. He exercises regularly, 30 minutes, 3 to 4 times a week. Prior history of tobacco use, but quit, and no drug use. He had a father with an MI at age 67 and mom with hypertension. And family history gets really important when people present with early coronary artery disease. So for women, it's less than age 55, and for men, less than 65. And on exam, pretty unremarkable vitals and physical exam. So, in someone like this who comes to the office, it is 100% appropriate for us to assess his traditional cardiac risk factors and calculate what's called an ASCVD risk score. And this is something that we can literally type in. Like, I have an app on my phone where I plug all the information in, and it spits out a risk for you. So it talks about a 10-year risk of having a cardiovascular event. But no risk calculator is perfect. It's not necessarily appropriate for everyone. So people may have their risk underestimated if they have HIV, some type of autoimmune disease, different ethnicities. So people of South Asian descent have a higher rate of obstructive coronary artery disease, or it may also be underestimated in people with socioeconomic disadvantage. So it's not perfect, but I think it's a good jumping off point. So you're low risk if your 10-year risk score is less than 5%. So I think that you could, continue doing everything that he was doing. But then it gets more interesting when it doesn't get more interesting. It gets more challenging when your risk increases. So your borderline when your 10-year risk of a cardiovascular event is between 5 and 7.5%. Your intermediate is between 7 and 20, and your high is greater than 20. So it's really easy to know what to do with the low risk and the high risk people. But it's the intermediate one that we kind of want to have to tease through a little bit more. So if you're borderline or you're intermediate, I think the questions are, well, what can we do to mitigate risk? So for most people, that will mean really tight control of hypertension, tight control of cholesterol, diet, nutritional counseling, exercise. So one of the things that we can do in order to kind of increase or decrease where you sit on this risk score is to do something called the coronary calcium score. And this actually has become really a useful tool to kind of help redefine someone's risk on this risk score. So it's a really easy study. It's super quick, but it gives us a lot of information. So on the left, you have this coronary artery calcium score is 0. And so what we're looking at are these. This is the LED, and you can't see the RCA here, but what we're looking for is this. Everything looks kind of the same. It's kind of all grayed out. But this person on the right has a really high coronary calcium score. You see all that calcium or in the coronary artery suggestive of established plaque. So this person on the left and the person on the right, I would treat very differently in the office. But it sort of helps redefine how aggressive we are in the office. So if you look on the right, I think it's really important that as your coronary calcium score increases, your risk of a coronary event also increases. And it doesn't take a super high coronary calcium score to increase your risk. So, obviously, a calcium score of 0 is perfect, and that's wonderful. But as you sort of increase to greater than 100, your risk of a cardiac event increases. And so I think that's why we tend to be more, or that's why I am more aggressive in managing patients as an outpatient, because I want to help try and mitigate that risk. So the treatment threshold tends to be a calcium score greater than or equal to 100. But obviously we want to take everyone's preferences into consideration. So, I don't necessarily start an aspirin and statin on everyone. I would love to, but I think people's preferences also have to play a large role in decision making and therapeutic management. So this is a busy slide, but ultimately what this is saying is that there are people who are very high risk for coronary disease and should upfront be managed as a higher risk group. So those are people who are older, who have diabetes, and who have familial hyperlipidemia. Those people should be on a statin. And then everybody else, sort of falls into these risk categories. So if you're borderline risk, and let's say your calcium score is high, then I would actually shift you into the intermediate risk and then have a really fun conversation about aspirin and statin therapy. And ideally, we want to reduce your cholesterol or your LDL by about 30% to reduce that risk. And obviously, if you're at high risk, if your risk score is greater than 20%, then we want to be really aggressive and lower your LDL by at least 50% if possible. And on the left here, this is sort of speaking to, like I said, the ASCVD risk score is not perfect, and there are different people in whom the risk is underestimated. So those are people who have a family history of coronary artery disease or premature coronary artery disease, who have an elevated LDL greater than 160, but haven't met the familial hyperlipidemia thresholds. Chronic kidney disease, metabolic syndrome, inflammatory diseases like lupus and RA. And actually women are at higher risk if they've had preeclampsia or other complications from pregnancy. That can also be an increased risk factor. And as I said, ethnicity also plays a role in this as well. And so one of the other things that I'll get into later is, other options for, changing your risk score. So we talked about coronary artery calcium as one of those. The other thing I'll talk about later is, I don't know if you've heard about lipoprotein a, but that's another thing that can help kind of increase or decrease your risk. So other things that we talk about in the office for folks who are coming in for screening are nutrition and diet. So obviously as plant-based as possible is ideal. And most folks who ask me what kind of diet to follow usually recommend a Mediterranean diet. So fruits, vegetables, fish, whole grains, nuts. Those are the typical, that's the typical recommendation that we'll give. In terms of physical activity, it's 150 minutes a week of moderate intensity activity. And I'll admit that I struggle with that too, but I think that I think it's important once you sort of increase in your risk for having a cardiovascular event. Weight loss is going to be a big part of that. Lipid screening, blood pressure screening, and if they're smoking tobacco, we have to work to help get people to, especially if they're at higher risk, especially and not limited to if they're at higher risk for cardiovascular disease. So this is actually, I think, really important in terms of looking at blood pressure screening and kind of interventions that will help lower blood pressure at home. And this is what I talk to folks about in the office. So weight loss, 100%. Like if you lose weight, you probably will drop 5 points in your blood pressure. But the thing that actually helps most of all is actually a DASH diet. Like a healthy DASH diet will drop your blood pressure by about 10 points systolic. So I think that's really important to think about when you're looking to kind of try lifestyle changes to help improve your blood pressure. Obviously, lowering your sodium, potassium, and moderation of alcohol all will help. But I think when I first looked at this, I think that was what surprised me the most. Okay, so we talked about the coronary artery calcium score. I just want to shift a little bit to other things that we can help to understand what your cardiovascular risk is. So lipoprotein little a, or LP little a, is sort of like an LDL particle, but which is the quote bad cholesterol. It's comprised of the LDL plus a couple of other different components. And it's made in the liver, and it does a lot of things, but it's thought to increase atherogenesis, thrombogenesis, so blood clotting, and it has pro-inflammatory properties. And it's actually high in about 20% of the population, so this is not something that's super rare. And, you know, why is it important? So it's established as an independent risk factor. Coronary artery disease. But in general, the lipoprotein A levels are genetically determined, and there's not a ton of change up or down from environment or lifestyle factors. And there's no generalized consensus, but I would say what we take as high is something greater than 50, and low is less than 30. So in someone who comes in, and I've done this lots of times before, and someone who comes in relatively young, so less than 50, coming in with an MI, I will check their lipoprotein little a in the office to kind of understand, you know, as like a 40-year-old person coming in with an MI is not common. It's pretty rare, or becoming increasingly less rare. But I will check this to kind of understand risk, and that helps me become more aggressive about statins and blood pressure. So how can we lower lipoprotein little a? So I just got done saying that there's not a ton we can do to move it up or down either way. But in general, that will make me become a lot more aggressive with my patient about counseling for diet and exercise, and all the things that we already talked about. So medications, is there a medication that can help decrease lipoprotein little a? So statins don't really, again, change lipoprotein little a one way or the other. The two that actually do lower lipoprotein little a are the PCSK9 inhibitors. So those are the injectable cholesterol medications that are administered every other week, and they do lower lipoprotein little a pretty aggressively. And then niacin also will as well, but we've moved away from using niacin as part of our armamentarium for lipid management. Yeah.
When it comes to diet, you said Mediterranean. Where does chicken fall into that? Is that still a good option? Or?
Yeah, it is. I mean, I think I would try and stick. I mean, I usually tell people chicken breast rather than chicken thighs. But yeah, I think that's reasonable. I just usually try and tell people, like, avoid red meat if possible. I mean, I also like to live my life in moderation, so I don't cut it out. But if you're 40 and you've come in with an MI, I will probably counsel that person a lot differently than like a 65-year-old who came in at the same time. So I think it's all about like lifetime risk and what we're doing. But yeah, you know, I would never tell someone not to eat it for the rest of their lives, but I think moderation or a decrease is important too. But I will say for this, there are medications coming down the pipeline for lipoprotein little a, and I think that those trials are going to be important because, to be perfectly frank, we know that it increases your risk of cardiac disease, but we don't know that lowering it decreases the risk. So right now, there's no real benefit right now to lower the lipoprotein. We just have to work on everything else right now for that stuff to come out. And again, I'm sorry that all the things kind of came out all funny. So final thoughts. I would say for people who are coming in either to the ER or to my clinic, who come in with chest pain syndromes. I think the big thing is we have to risk stratify them and then understand that stress testing and coronary CTA are really good first line tests, and which one you choose kind of depends on the patient and what they feel comfortable doing. A coronary CTA has, I would probably say, a better negative predictive value. So if the test is negative, then the chances of you having coronary artery disease are very, very low. And then it's less specific than a stress echo. So a specific test, if something is positive, then it rules in coronary disease. So it's less so than the stress test. And obviously everything that we do in terms of testing depends on the prevalence of disease. So if you don't have disease and you just start testing everyone, you're going to get a lot of negative tests. And is that the right thing to do? And even asymptomatic patients need to be routinely screened for their cardiovascular risk and undergo counseling to help reduce that risk. So I successfully convinced Jimmy to go get screened. So I hope everyone here has been screened or is being screened.
We fed them all chicken fried steak.
Well, don't check your cholesterol right now.
There was a salad option.
Yeah. It was vegetables.
Yeah.
Thank you. Any questions?
Thank you.
No, that's my pleasure.
I really think this applies to your personal lives directly, especially being firefighters and the lifestyle we live. And so some good thoughts in there for us. And the screening is important for us to get done and make sure we keep ourselves healthy. Also, all these tests and everything you're screening you're talking about are available here, right?
Yeah,
so your
absolutely.
chest pain patients that aren't the STEMIs, that aren't the critical ones right there, they can come here and get started in the process.
Yeah, I mean, I think these are calls that I get from the ER all of the what do we do? That's part of my job to help and steer people. This is that first patient could very easily have presented to the ER, very easily so I think it's about across the board.
Awesome. Thank you so much.
No, my pleasure.
Appreciate you.
I hope it helps.